founding premier tutors at Princeton Review and runs his own test prep company, GGG, and provides content consulting services for others. Glenn was a founder and longtime co-chair of the Runners Advocacy Organization, New York Road Racing Ombuds Association. His acute onset neuropathic experience in 2003 led him down the path of extensive volunteering and advocacy work for those suffering from neuropathy and other neurologic conditions. Glenn is married and has a adopted son from Korea. Glenn has predilections for Arctic dog breeds and fig Newtons.
That's right.
Welcome, Glenn. Glenn has been a fantastic new addition to our board of directors. So welcome, Glenn, and it's all yours.
Thank you. As I like to say, you have to remember fig Newtons are not cookies. They are fruit and cake. So, and that's important to know. So I'm going to do a little sharing screen. I put together, yes, it's another PowerPoint that I'm going to try and share with all of you. And hopefully this will pop up quickly. For lack of a better title, it says My Patient Journey, but this is not only going to be about my patient journey. This is going to hit a lot of points about neuropathy as we go. Feel free, by the way, to throw questions into the Q&A. I'll absolutely field them later on. And, we'll talk about a lot of aspects of neuropathy. I may even add to a little bit of what our neurologist presented before, based upon research that I have done and the affiliation I've had for a long time with the Cornell Weill Center for Peripheral Neuropathy. They like me there because I'm an interesting patient. And basically the idea is, as I said before, I have a presentation of neuropathy that's rather unusual compared to most people's. It was acute onset, it was body wide, and I am living proof that nerves do regenerate. There is skin biopsy evidence in my case that over the years they have, although probably not to their original status. So I'm going to talk a little bit about how this all came about, and I'll comment as I go. I'll talk about like when this all happened. It's quite old now, but let's see if I can get this to come up. Here we go. So basically, and I remember this like it was yesterday, and I lived on Staten Island, New York at the time, that I first noticed on April 12, 2003, at about 11:30 a.m., because it was such a weird sensation, some tingling and weird paresthetic sensations under the fourth toe of my right foot. I noticed this stepping out of a shower, believe it or not, and I did not know what to make of it. This was not something I'd ever had before. And up until, this point, I was disgustingly healthy. But basically what happened is that as the day went on, this tingling sensation became a burning that encompassed the whole foot. It moved up through the foot. And in 12 hours, it was also starting on the other side and traveling up the right calf. Very disconcerting. Again, I'd never experienced anything like this. The only other nerve symptom I'd ever experienced is basically whacking my elbow on something and causing that ulnar nerve to vibrate for a little while. But of course, that went away quickly. So basically, I didn't know what to make of this, but, 43-year-old guy experiencing this, supposedly like, really healthy and stoic, didn't think all that much about it, although it was rather painful. But things got worse over the next couple of days. The burning sensations didn't stop there. They basically climbed up my entire body, eventually encompassing all the skin surface. This, as you can say, is a problem because now the slightest touch was agonizing. Breezes wafting across my skin was burning. Basically, and this is the way I've characterized the pain. It'll be one of the things that'll get me into Bartlett's quotations, if anything does. People ask, like, what was it like? So I said, it's like having a severe sunburn over your entire body that's been rubbed with steel wool. I was not able to eat. I was not able to sleep. I was certainly not a happy person. My young son was very, very concerned. My wife was going crazy over this. We tried to begin to find neurology appointments as quickly as possible. But being that I was on Staten Island, and even though I had decent insurance, that took a while. I finally wind up in a local neurologist's office. He shall remain nameless. On April 21st, testing was started. They did the usual pinprick type of tests, the usual reflex tests. I could certainly feel the pinpricks. In fact, I could overfeel them. Reflexes were fine. A lot of blood was taken, urine was taken, appointments were made for an MRI. And I now know, and there's a little indication of this a little bit later on, the suspicion 43-year-old guy presents that acutely is first attack of multiple sclerosis. That's what the presumption was that they were laboring under. And that's why they wanted to do, obviously, all this, particularly the MRIs. Fortunately, they gave me a prescription for gabapentin, Neurontin, some of you know the actual brand name as. And fortunately, from the first 100 milligram dose, some of the symptoms were alleviated, which was great because this was now 9 days in. Finally, I was able to get some sleep that night. I had, not been sleeping, not been eating. I'd lost more than 10 pounds at that point. I was in a bad situation and didn't really know not only what was going on, but if I was going to survive this. I was fortunate that the gabapentin worked. I would actually ramp up the dosage fairly fast. So upshot of this, okay, over the next week, the pain, while reduced, continued. We ramped up the gabapentin dosage pretty quickly. Fortunately, I didn't have that much in the way of side effects beyond a little fluid retention, beyond somewhat of drowsiness, but I was able to handle that. The other, of course, joke about gabapentin is that it'll cause you to lose 20 IQ points. I like to say, fortunately, I could afford that. Not everybody agrees. On April 24th, I went in to get various MRIs of brain and cervical spine. There was no evidence of multiple sclerosis lesions. And because of that, and because nothing was coming back really from the blood workup or the urinalysis, decisions were made to do much further testing as a hospital inpatient at Staten Island University Hospital, which I entered on the 28th. Now, as I said, I'm fortunate that I had good insurance for this, because otherwise I'm not quite sure what would have really have happened. Where am I with this? Okay, so basically inpatient testing in the hospital, more advanced blood work, urinalysis, more MRIs, thoracic and lumbar spine, and spinal tap. They were really looking for those multiple sclerosis lesions. The spinal tap story is fun in and of itself, which actually says a lot about our medical system. They sent in 2 people, very, very tiny, to try and do a spinal tap on me. Now, you have to understand, I'm 6 foot plus, 200 pounds plus. The 2 young nurses they sent in to do this, I probably outweighed the total of them. And they could not find my actual spinal canal. They did 3 punctures at the base of my spine. And I want to tell you that hurt. It's, our presenter earlier on talked about like the discomfort from spinal taps. Discomfort is not quite the word to describe this. And because they couldn't actually find the canal, they then actually sent me down to fluoroscopy for X-ray to actually do it under imaging. And the interesting thing about that was they gave me a local, they did it under imaging. It was done in 3 minutes. To which, of course, I then said, why the hell did you not do this to start? And I was told that apparently insurance won't pay for it unless you can actually show failures in the actual attempt to get the spinal tap. This probably right at that point presaged the coming career I was going to have as a healthcare advocate, because that was enraging. But the gabapentin dose was now up to 1,800 milligrams a day. I was able to be at least a little bit functional. I was discharged back to the neurologist, but nothing came back from the spinal tap or the other MRIs or any of the blood work either. So now basically I have completely normal and negative testing, and I'm still burning, even though I actually have a little bit of functionality now, and I can eat and sleep again to a certain extent. This is where the Princeton Review background helps. For those of you not familiar, by the way, with Princeton Review, it's a test prep organization. It was actually founded in the 80s in contradistinction to Kaplan. I was one of the original master and premier tutors there. Basically, we came up with a lot of the stuff that some of you who have sons, daughters, nieces, nephews studying for standardized exams got the techniques for. Basically, though, it meant that I had access to a lot of medical subscriptions because we do the MCAT. And as a result, I started doing a lot of my own research. First, I realized I was going to have to get some more advanced opinions now at major hospitals in Manhattan, where at least obviously there were research facilities. Basically, I wound up with the New York City Neurology Group, which is affiliated with NYU. That's where I had my first nerve conduction studies. They hadn't been done until that point. I had those and evoked potentials, which is something, again, they will sometimes use to spot MS or other demyelinating conditions of the brain and spinal cord. Still or normal and negative. I do not have sensory disruptions. I do not have blockages. I do not have motor symptoms, just the severe burning dysesthetic pain. Now, of course, owing to the fact that I'm doing so much research, I come across through things like PubMed and a number of the other aggregators of the medical situations, some of the papers that indicate that this could be an attack of small fibers. I basically eventually, reading several dozen papers, come to the idea that I may have experienced an acute onset autoimmune molecular mimicry small fiber nerve attack, analogous to Guillain-Barré syndrome. And for those of you not familiar with all that, the idea is that your body is invaded by a pathogen. And I had a cold a couple of weeks before all this started. The theory is that your body produces a immune response, probably even fights off the pathogen. But if the pathogen has a molecular structure similar to some component of peripheral nerve, the now activated immune system no longer can tell outsider from insider and attacks any body tissue that looks like that. This is thought to be the mechanism beyond Guillain-Barré syndrome, which is an acute neuropathy that basically attacks myelin sheathing as well as the axonal interior fibers. It usually is directed against particular components of myelin. And as a result, and I'll talk about this a little bit more later, that's why it often has motor symptoms in addition to sensory ones. These small fiber nerves are the nerves that subsume the sensations of pain and temperature. They are not covered by myelin sheathing. Myelin sheathing does cover larger sensory nerves that subsume the sensations of mechanical touch, vibration, and position sense. And myelin also covers all motor nerves, which you usually find in those larger nerve cords that our neurologist spoke about earlier. But the other thing that I learned is that while there are other tests for small fiber neuropathy, including qualitative sensory testing and pseudomotor axon reflex testing, which is that one where they cover you with the purple powder to see how well your sweat works, because autonomic functions like sweating, pulse, blood pressure are also controlled by unmyelinated small fiber nerves. The real gold standard, at least in 2003, still really is, was skin biopsy. This is not the same as nerve biopsy, which normally takes a large sample of a myelinated nerve, usually at the ankle. Skin biopsy is often done in the upper arm, the thigh, and the lower part of the calf. And what they're looking for, and it takes an electron microscope to see this, is the density of the small unmyelinated sensory nerves and what condition they're in. So I managed to wrangle an appointment at the Cornell Weill Center for Peripheral Neuropathy, which is one of, at the time, 2 New York City medical centers that does this procedure. The other one, of course, is Columbia Presbyterian. They're both under the New York Presbyterian umbrella, but Cornell was closer and has a research facility. So basically, I wound up in there on July 23rd. Most extensive physical I will ever get. Fortunately, one of the advantages of going to a major research hospital with a research orientation into peripheral neuropathy is that the doctors can spend time with you. They're not being paid by the patient. So basically, it was a full exam, not only neurological. They did everything from an EKG to basic, testing of, just general lung function, and some highly detailed neurological testing. It's where I was first introduced to something called a von Freyhair, which is a small filament. They have filaments of basically different calibers and thicknesses to see what you can feel when they touch them to you. So it's more than just the usual pinprick test many people are familiar with. Advanced autoantibody blood work. What Cornell is most famous for under Dr. Norman Latov is discovering a lot of the autoantibodies to peripheral nerve components. So they basically tested me for all the ones they were aware of there. And of course, the skin biopsy. I had actually explained what I thought was going on to the neurologist there, and they seemed to think that there was a pretty good supposition on my part. They asked where I found out about that, and given the eidetic memory I have, I basically quoted them chapter and verse, including some papers that they weren't as familiar with that came out of Europe. And basically, we waited for the results about 7 days. All the testing was normal except the skin biopsy. There was significant reduction in intraepidermal nerve fiber density. I was at the 3rd percentile. Anything below the 5th is considered definite evidence of small fiber neuropathy, although you can have the amounts, really percentiles above the 5th percentile and still get a diagnosis depending upon the condition of the fibers. And mine were in really bad shape. There was evidence of swelling and degeneration. One of the doctors there said that some of them looked like they'd been exploded from the inside. This was the only test that I had ever had, and I've had so much of it, which provided unequivocal evidence of neuropathy. Okay, so the upshot of all this, now is basically without direct evidence of autoantibodies, which is going to be interesting, I'm sure, when John talks about his journey tomorrow, immune modulating therapies were not recommended. I can tell you that Cornell does things like IVIG and plasmapheresis quite commonly if autoantibody activity can be demonstrated. But since I did not, and the supposition was that the autoantibodies that might be involved might be unique to me and not necessarily having been even discovered yet, treatment was going to be palliative, They did suggest that since I had acute onset symptoms, there was a strong possibility of regeneration. Turns out they were right, and we'll talk about that. We increased my gabapentin dosage to 2,400 milligrams a day, which I stayed on for about the next year and a half. Now, there's a good news, bad news aspect to this, which I'll talk about. I had follow-up appointments at 6-month intervals for the next 2 years. By early 2004, symptoms began to reduce slowly. And so under the medical supervision, I began to slowly ramp down the gabapentin dosage. It took me the better part of 9 months to do that. I basically was going down about 100 milligrams every 2 weeks. The reason you do this is gabapentin was originally developed as an anti-epileptic, which basically means that there's a chance if you go and wean down too quickly of getting rebound seizures in addition to increased pain. Nobody wants that. But I was able eventually, by almost the beginning of 2005, to get down to a 0 dosage. Still had some symptoms, but nothing like they originally were. And then, of course, since I'm such an interesting patient, they did a follow-up skin biopsy at the 2-year mark. I was up to 17th percentile of intraepidermal nerve fiber density at the locations. The good thing about skin biopsy, where they really just take like a 3 millimeter patch of skin and then just slap a Band-Aid on it, it's not like the nicest thing you'll ever have done to you, but it's much less invasive than a nerve biopsy. And it can be repeated over time from the same areas. So, and I've been getting, by the way, subsequent skin biopsies about every 3 years since. I'm up to, at this point, about the 30th percentile. That's considered normal. You just really don't know in the end where you started, because except for some research problems, particularly at Johns Hopkins, where these norms were first standardized, people who are experiencing no symptoms don't go for skin biopsies. So let me see, what did I actually skip over here? Here we go. So basically now, and we're going back now about 19 years, symptoms have greatly waned over the years. Subsequent skin biopsies show slow but continued nerve regeneration. My symptoms are about 90% gone on a good day, and maybe on a bad day, 75%. I'm still prone to flares and compressive nerve effects due to regeneration in alternative pathways. The theory, of course, with this type of stuff is that when nerves regenerate, particularly the small fiber nerves, they have to fight their way through and around other tissues, and they will not wind up in the same pathways that they originally were. So it's very, very easy to compress them and cause symptoms. In fact, a lot of people who've been through this, now that I know from various communities I've been involved with and boards I've been on, is that a lot of people will often have upticks in symptoms for a while, even during nerve regeneration. And of course, the people who have traumatic neuropathies from injuries and then have nerve healing report very much the same thing, that they'll have extensive flares that go on for weeks or months and then gradually subside as the brain gets used to the new signals that are impinging upon it. It turns out that what happened to me is somewhat rare, but it might be considerably underdiagnosed. Due to my and others' similar histories, the descriptive entity ASFAN was coined. I have actually been talked about in medical papers, although they usually don't mention the name, due obviously to confidentiality issues. But sometimes when people bring up a paper, I will actually tell them, yeah, I was part of that study. ASFAN stands for acute small fiber axonal neuropathy. It's a great acronym. All we need is one more S. But basically, what this actually showed was that there are weird presentations of neuropathy. Yes, it's probably true that the majority of people have the slow on of diabetic neuropathy, starting from the toes, working its way up, maybe getting into the hands and fingers. But it's not the only presentation of neuropathy. There are acute onsets. There are subacute onsets over weeks to months. There are people who experience symptoms first in other parts of the body. It's not always toes and fingers. And of course, all this I have learned through research. I'm fortunate to have been born in an internet era. I'm fortunate to have access to a lot of medical sites. But understand that before all this happened, I knew nothing about this. Okay, there was not a thing that I could have told you. I hadn't even heard about what neuropathy was. And it's the reason why, as at least the symptoms, wound down enough for me to become involved, that I became involved in the Neuropathy Association, which unfortunately is now defunct. I was part of a very important neuropathy summit in Washington, D.C. in December 2010, which was I first met Bev Anderson. And basically since then, in various, ways, shapes, and forms, I've been involved being an advocate for knowledge about neuropathy. It's the most common ailment that nobody knows. It's estimated 1 in 15 people will experience it over the course of their lifetimes. And unfortunately, part of my advocacy work led me to the conclusion that our organizations were small, not well funded, and often didn't play well with each other. A big part of my getting involved with WNA is to be a liaison and help the organizations play well with each other. So this is a story. Obviously, it's mine. It's unusual, but I think it provides some hope as well. Neuropathy is not necessarily something that is going to be everyone's fate for the rest of their lives. There are ways, if one can find a cause, and if it's a cause that's treatable, to actually treat it and reduce symptoms. yes, there are people out there labeled as idiopathic, although I suspect that a lot of those people labeled idiopathic, from, again, the research that I've been privy to with Cornell and other places, is that there are autoimmune or metabolic mechanisms involved that just haven't been described yet. There may also be genetic causes involved. The Human Genome Project has revealed innumerable small groups of hereditary neuropathies. There are so many of them that the database to list them, the best database I know, by the way, I'll talk about this tomorrow, is at the Washington University at St. Louis Neuromuscular website. Since I first started consulting on that website, the number of hereditary neuropathies listed has quintupled at least. That's what we're discovering genome-wise. So there's probably still more of them out there. There is definitely evidence that people who have dysregulation of glucose that's not frank diabetes may suffer neuropathy even before diabetes is diagnosable. And of course, there seems to be more and more autoimmune neuropathies diagnosed as we learn more and more about autoantibodies. Again, more of this we'll talk about tomorrow. And obviously, people who have questions or want to know more about this, I will obviously field them. But I have, at this point, considerable expertise in this. Doctors consult me, I'm very proud to say. There are people in like the heart units at Staten Island University Hospital that call me when they have a neuropathy question. And a lot of this is due to having an eidetic memory, as I said, so I read sites and I just remember it all. But I do tell people that in the end, that it's not, for most people, not only not a death sentence, but it's not necessarily a complete morbidity sentence. And I'm hoping that with obviously advocacy, with more money into research, we'll have more and more treatments that are actually developed, and not just palliative treatments, treatments that will actually help heal nerves. Nerves do heal. They heal extraordinarily slowly. Under the best of circumstances, 1 millimeter a day is a figure that is often quoted. Of course, that means if you've got like a small fiber that goes from your lower spine to your toes, you could be talking about 3 to 5 years. And that's only, of course, under optimal conditions. But it is possible. And, I try and tell people that, there is hope for this, for the people earlier during the presentation worrying about when are we going to have a treatment. I think one day we will. Or we'll have multiple treatments for multiple types of neuropathies in the same way they're going to have multiple immune modulating treatments for many different cancers and autoimmune diseases. So I figure I'll sort of like, sum it up at this point, let people throw questions at me. I'm looking to see like what we have. I should basically at this point kick out of the screen share unless anybody wants me to keep it up. I'm looking into the chat. I want to bring that up if I can. Let me see if I can do that.
All right. I just want to say that really Glenn knows so much, and he is like our medical expert when we have our virtual support group meetings. Somebody will ask something and I'll go, Glenn, do you have an answer? So really you have the opportunity now. He's here. If there's something particularly about your neuropathy that you'd like some more information on, or some term you don't understand, Glenn will know.
Yeah.
Or John will know.
It's
Glenn
yeah,
or John.
Or John, or John will know. It's time. It's time to pick brains, basically.
One of them will know. I'll just point the fingers and say who's going to talk.
Yeah.
So we did have comment. I mean, Katie said your talk was fascinating. So that's good.
Were there any questions from before with Dr. Zhang that maybe either of you wanted to provide more insight on, or something that she maybe glossed over that you thought could use some more detail?
Well, I could talk a little bit about the say, the impaired glucose tolerance situation. There is a lot of medical literature out there, and if anybody wants to, I can probably flood your email box with it, that seems to indicate that given the upturn in diabetes and in impaired glucose tolerance before frank diabetes, that there are a lot of neuropathies that people think are idiopathic that may be caused by this. There's demonstrable small fiber nerve damage in people before they actually get to a frank diabetes blood sugar level. It's another reason why I tell people that even if you have a neuropathy that is not diabetic in nature, it's good to treat yourself as if you are. Watch that sugar intake, keep your hemoglobin A1C in a very nice level if you can. You try very, very hard, to maintain a good diet. Try very hard to build muscle. Muscle is less insulin resistant than other tissues if we're talking type 2 diabetes. You really want to try, especially since as we get older, obviously, we tend to just lose muscle tissue just as a result of aging. But you can't build muscle with age. I certainly have. You got to commit to it. You got to lift weights, and you got to do, even if you do, light weights and many reps. But that's as important as the aerobic exercise we all need, just because you want to make sure that you have that tissue there that helps to regulate your insulin and glucose levels. The other thing that I could make a mention on, somebody had asked a question about cryotherapy. There are certainly people out there, most of them not neurologists, I wouldn't think, but there are, say, chiropractors and physical therapists who do sort of nerve ablation therapies. Sometimes they do it with cryotherapy, with nerve freezing. Some people do it with lasers and heat, where basically they're just burning off the offending nerves. I don't know how effective that would be for a systemic peripheral neuropathy, though. If you have what they call a mononeuropathy, you have a pinched nerve that you just can't get released, maybe if they burn that nerve ending, that helps. One of the actual conditions, a neuropathic condition that I know of that they use this for, is something called neuralgia paresthetica, which I don't know if any of you know about. It basically involves the compression of the lateral femoral cutaneous nerve, which is a nerve that comes out of the back of the spine, down the sides of the buttocks, and into the outside of the thigh. It's a purely sensory nerve, and it doesn't go beyond the upper part of the knee, but it is very easy to compress that nerve because of what goes on in the pelvis, which is very crowded. So people who have, say, lumbosacral issues or have pelvic issues, this is a common mononeuropathy. There has been some success with cryosurgery for that because it's a fairly large nerve. It's easy to spot, on fluoroscopy, and you can actually burn off the end of it. Although the problem with it is that, again, nerves can regenerate over time. And if you're a healthy person and that nerve regenerates, you may have the symptoms again. Catherine says.
So there's 2 questions in the chat.
Okay, let's get. Okay, I have had neuropathies for about 2 or 3 years, but I'm getting little guidance on what to do about it. How do I find a place to go to or a doctor to go to help me make progress? A lot of it, Michael, will depend upon where you live and what's available. And of course, what insurance you have, which of course I feel depressed every time I say. I am of the opinion, okay, and I realize this is not universally shared, that if one has a neuropathy that's idiopathic and is not getting a lot of guidance and is mostly seeing neurologists in private offices, it's well worth getting a second opinion from a major teaching hospital, particularly one with a neuropathy center. Among those, obviously, there's some in New York, there's Cornell in Columbia, Massachusetts General, Jacksonville Shands in Florida, the Jack Miller Center in Chicago, the Mayo Clinic either in Arizona or Minnesota, whatever you're closest to. In California, one of the best places is University of California, San Francisco, which is where Ann Poncelet, who I'll introduce you to tomorrow, has worked for a long time. These are all major centers of research into neuropathy. And although the waiting list might be long, it's not a bad idea to try and wrangle a second opinion consult there. Often these are places where they can do advanced autoantibody or other testing. They may have other ideas about, like, doing genetic testing for certain causes. So that's, basically what, I try to recommend. And I realize, yes, it may be hard, if you're in a small rural town in West Texas, it may be hard to do this. But Michael, if you want, you can tell me where you live and I could probably give you some suggestions. Or at least places that are close.
And the other thing is come to our virtual support group meetings, because we have lots of people that are newly diagnosed that get the same diagnosis of you have neuropathy, you have to live with it. And they come to the meetings and listen to what everybody else does with their neuropathy. And you can learn a lot in the meeting, especially since you've got Glenn and John there. And so that's something else I suggest if it's not possible to go off and get to a doctor. Glenn, someone asked who was the UCSF person that was Poncelet. What is her name?
Yeah, Ann Poncelet. I don't know. I wonder if I could pull up real fast. I mean, you will see this tomorrow when I do my presentation.
Don't do it. I'm saying don't do it because we've got more questions. So
okay, but Ann Poncelet wrote a wonderful paper. It's about 24 years old now, but it's still excellent, called An Algorithm for Diagnosing Peripheral Neuropathy. It has wonderful charts and wonderful flow through situations there, and it's a very, very good starting point for, given whatever people's symptoms and test results are, what they should be doing next. And Lolene is asking about chemo-induced, right?
Well, kind of. She's saying, yeah, that her. So does chemo actually kill the nerves when?
It certainly can, but don't take their word for it. All right. I certainly have experience with people who have had chemo, who have gotten regeneration of other nerves around dead nerves that took over the function. The idea, of course, first is chemo has to be over, because if you keep doing it, you won't be able to do it. And then you really have to try and maximize your oxygen and nutritive abilities. You want to do exercise, to improve circulation, because obviously the more circulation, the more oxygen and nutrients you can get to the nerves that are still in the area, and the more toxic waste products can be carried out of there, the better off you will be. Yes, I agree. Chemotherapy is a major neuropathy pain. A lot of oncologists don't even mention it when you start those heavy metal or other, neurotoxic regimens. They really should. But most people with chemo-induced neuropathy over time, and it may be a lot of time, so I apologize for that, will get some function back, although, as with many other acute onset neuropathies, the function is often patchy and incomplete. But since nerves can regrow, you can get nerve fibers into areas where others have been killed. And it may be a very, very interesting and weird set of sensations while that's happening. But, depending upon Lolene, how long the chemo's been over, if you can get your nutrition optimized, you may get some function back in time.
So
Michael just said he lived in Connecticut. I'd absolutely say come into Cornell. There are people there I can tell you to see, even if you're in Upper Connecticut, or if you're in Upper Connecticut, you want to go the other way, Massachusetts General, MGH.
There's a question, go to the chat box. There's a couple of people that asked something. Judith asked specifically about your story. She said the only treatment you had was gabapentin. Yep. How would this have helped your nerves regenerate? Also, have you experienced onset tick by something tumor in the spine?
Okay, to separate these into three questions, which I can address. I'm sure gabapentin did not help my nerves regenerate. I'm sure what happened is that basically the autoimmune process burnt out sufficiently that my body's own ability to heal slowly and naturally eventually helped do some healing. The gabapentin was for palliation only. It's basically for just removing some of the symptoms while things were going on. Now, have people had experience with onset after tick bite? Oh, you better believe it. Lyme disease and a number of the other brucellus tick-related diseases are known neuropathy producers. There is some question whether it's from the actual invasion of nerves by the bacteria itself or through an autoimmune molecular mimicry reaction. It could very well be both, for all we know. And what is it? I can't even pronounce things.
I know.
Schwannoma tumor in the spine. Well, that is actually going to produce neuropathy through compressive forces. I mean, that's not as systemic a neuropathy, although depending upon where in the spine it was, you could get symptoms really from any level at or below where the tumor is. I always tell people, because I also have the problem of cervical spine difficulties. I have arthritis and disc problems there. And those symptoms are actually very different from my small fiber neuropathy. There's a lot more like tingling, motor, occasional numbness, which I did not have with the small fiber neuropathy attack. It's transient though. As long as I keep really working with the physical therapists and doing the exercises and doing the traction, I've managed to stay out of the operating suite for about 15 years. Most of it, by the way, is because I was an athlete in my youth and I used to play rugby. Rugby, for those of you who know it, is football without equipment. And it's probably, you know, no great surprise that I have cervical spine issues as a result.
Yeah.
You know, when you're 17 and you're an idiot, you'll play rugby.
Okay, Glenn, one more question. The other question in the chat, Katie asked, Catherine asked, how would we go about getting a skin biopsy at Kaiser, which is still California? But she says no feeling in foot or ability to
circle ankle. Yeah,
ankle.
I mean, I have no idea. I don't know if Kaiser does skin biopsies. You may not be able to get it from Kaiser. You might have to go someplace else to get it, or have them like recommend you up to a place like UCSF or one of the other facilities. Basically, you know, anybody who has, and this is, you know, I'll talk a little bit, you know, not specifically to rhabdomyolysis, anybody who has an autoimmune molecular mimicry blood disorder is prone to neuropathy. My wife, until recently, worked for the Lupus Research Alliance, and you'd be amazed at the number of people with lupus who have neuropathy, and the number of people with related diseases such as this one, and Behçet's, and polyarteritis nodosa, and scleroderma, who actually have neuropathies as effects of these diseases. Some of it is from compression. Some of it is because these are diseases where there's autoimmune attack on blood vessel material. And so basically blood vessels are compromised and you wind up with, again, lacking nutrition and oxygen and toxic buildup of waste products. You know, we've often talked about there's over 200, you know, causes of neuropathy. Certainly with the hereditary ones now, there's a lot more. But a lot of the ones that are more well-known, or at least should be well-known to specialists, include these autoimmune molecular mimicry, vascular disease